Yes. So actually, if you see in NEET perspective, in with respect to medicine, if you see last 3 to 4 years, in CVS they are concentrating always 4 to 5 MCQs will be there. Okay, and apart from this, ABG if you see, there is again 4 MCQs, and apart from this, this RUMAT usually they will say they will take some 2 or 3 MCQs. Then if you see CNS, they are like 2 or 3. Okay, actually, since in this INICET, what happened was, since NIMANS was also included, they actually asked too much questions on psychiatry as well as CNS. Okay, so actually, with respect to NEET, it will be just 2 or 3. And then RS, if you see, there also they will be asking 3 or 4. Okay, so majority of the questions which they ask from CVS will be clinically oriented. Okay, it will be either decision taking questions or it will be either treatment regarding questions. So whatever questions I have framed in this quiz is entirely purely clinical based. Okay, nothing is like just single liner. It will be like clinical based and test your clinical skills, like physician working at PHCs to physician working at tertiary care. How will they respond to a clinical case? Okay. Yes. So can we start? So after this, we will be doing some clinical cardiology also in this upcoming week, like on the pulse, JVP, and heart sounds and murmurs. We'll be doing in the subsequent session. So yes, can we start? Can we start the quiz? Just say yes when you are ready. Okay. Okay. Let's start. So first question. First question is, all of the following drugs can cause this abnormality in ECG except all of the following drugs can cause this abnormality in ECG except A. Hydroxychloroquine, B. Azithromycin, C. Fluoroquinolone, D. Digitalis. Please answer the question with first you put the question number followed by your option, either A, B, or C, or D. All of the following drugs can cause this abnormality in ECG except hydroxychloroquine, azithromycin, C. Fluoroquinolone, D. Digitalis. Okay. Uh, a small clue I'll be giving now. The clue is just look for some interval in this ECG. Some interval abnormality is here in this ECG. The intervals we know are PR, QT, RR. Some interval is abnormal here, if you see, and that interval abnormality is shown here. Okay. Good. Ryder, Cole, Ashley, Nithya, Chelvan. Good. Let's proceed to the next question. Calculate the heart rate of this ECG. Calculate the heart rate of this ECG. Heart rate calculation is the most basic thing. So you can expect, if a question they want to ask some basic question in ECG, you can expect this question. heart rate calculation, you should never miss it. And in heart rate calculation, one of the tricky question is this thing. I'll help you put dots here for each box. Yes, yeah, given dots also. Now you can calculate it. Yes, good question, Ashley. Irregular heart rate, how to calculate it? That's why I put this question. Usually, heart rate you can calculate easily by just dividing the RR interval by number of large boxes. Like if it is for large box, you can divide by 300 by number of large boxes. Let's see. Let's discuss. Don't worry. Let's now calculate the heart rate of the ECG. We'll discuss in the solution. I'll zoom. See how much boxes I have shaded. Yeah, 30 boxes. Come on, start answering. Yes, good Sanjay Bharati, 6-second rule. Actually, if you take one large box, it is 0.2 second. Okay, I have taken 30 large boxes. So that will correspond to 30 into zero point 0.2, which is 6 seconds. 6 seconds, you see number of QRS complexes. Yes, good. Cool, Nishi. 6 seconds, you see number of QRS complexes. Actually, heart rate is for 1 minute. So it is 60 seconds. So what you should do? QRS, number of QRS should be multiplied by 10. Good. Let's move to the next question. This is a neat question. This is a neat question. Which of the following is true about stable angina? CPKMB is elevated, troponin is elevated, myoglobin is elevated, the levels of cardiac markers remain unchanged. Which of the following is true about stable angina? CPKMB is elevated, troponin elevated, myoglobin elevated, levels of cardiac markers remain unchanged. True. Okay. Nice. This was the recent NEET question. Nice. Let's move next to the next question. 25-year-old man complains of chest pain. An ECG was taken. An ECG was taken. What is the diagnosis? A 25-year-old man complaining of chest pain. Okay. So this ECG was taken, and I want you guys to tell the diagnosis from this ECG. A 25-year-old with chest pain, ECG was showing these things. Okay. So I want you guys to say the diagnosis. Is it RCA, right coronary arteries blocked, or left anterior descending arteries blocked, or acute pericarditis is going on, or hyperkalemia is going on? Come on, guess it. Nice variety of answers is coming. Okay. 25-year-old with nice. Let's move to the next question. What is the diagnosis from this ECG? What is the diagnosis from this ECG? Whether it's inferior wall MI, whether it's anteroseptal MI, whether it's high lateral MI, or whether it's anterolateral MI. What is your diagnosis? This is fifth question. So answer this question putting number 5. It's inferior wall MI, anteroseptal MI, high lateral MI, or anterolateral MI. Good. So can I move to the next question? So how will you, this question aims on how will you localize the wall of MI? What wall of heart is affected? With an ECG, how you can localize it? Okay. Let's move to the next question. Sixth one, the patient complains of typical anginal chest pain. He is saying a complaint is complaining of typical anginal chest pain. Okay. An ECG was taken, which was the next step of management. Okay. Anginal chest pain he was complaining. We did an ECG. The ECG was like this. Okay. The ECG was like this. So what will you do next? Next step in the management of this patient. Sixth question. Whether will you do angiography for the patient instantly, urgent coronary angiography, or whether will you check for troponins, or whether you do dopamine stress test, or whether you do echocardiography. What will you do for a patient having typical anginal chest pain and with the ECG like this? So this is like next investigation of choice like that. Can I move to the next question? Can I move to the next question? Okay. Okay. Let's move to the next question then. Next. So now they are asking to identify the artery affected. What coronary artery is affected? Just with an ECG, you are going to say what is the coronary artery that is affected. Whether it is left anterior descending artery or left circumflex artery or right coronary artery or it is non-localizable. You have given an ECG. Now you are going to say which artery is blocked. With this ECG, you are going to say which artery is blocked. Actually, there is 25 questions today. We will finish the first 15 questions and we will have a short discussion of the solution. Next, we will go for the next 10 questions and we will have the solution part. So this is like a question aiming to localize an artery, not with angiography, just with an ECG. Good. Let's move forward to the next question. This is one clinical scenario like a 58-year-old male complaint came to the PHC with 4 hours of typical anginal type of chest pain. BP was 120/80. Troponins were done, which was positive. Troponins were positive. ECG showed the following changes. Now, what is the next step in the management of the patient? You are in the PHC. The 50-year-old grandpa has come to your PHC with typical complaints of anginal chest pain for 4 hours. BP was normal, 120/80. Troponins were tested, it was positive. And ECG was this. So with this ECG, what are you going to do for the patient? First, you are going to refer him to a PCA capable center for urgent intervention. Next, you are going to start thrombolysis of the patient as time taken for shifting the patient to PC center is more than 2 hours. It is a more village. Okay, time taken is more than 2 hours. So what you think is you can start thrombolysis or give him loading dose and low molecular weight heparin and dual antiplatelets therapy you are going to start for the patient or refer him for angio CABG, coronary artery bypass grafting. What are you going to do for this patient? So this is like decision taking question. Good. Let's move to the next question then. Can I move forward? Okay. Next question. Patient has recurrent occurrence of chest pain. Okay. Has been having recurrent chest pain on and off for 10 days. And an ECG was taken. What is the next step of management for this patient? See the ECG properly. Patient is having recurrent occurrence of chest pain for the last 10 days and see the ECG properly. What will you do next for the patient? Angiography, cardiac markers like troponins or bypass surgery, or you will just leave the patient as it's a normal variant. What will you going to do for the patient? He is having recurrent chest pain on and off for 10 days. See the ECG properly and then tell what are you going to do. If the ECG has this finding, what are you going to do? Let's see who answers this properly. Can someone guess what's happening here? Okay, we'll go on to the next question. Which of the following ECG findings is associated with acute myocardial infarction? Recent question, neat question. Elevation of S wave, prolongation of QT interval, all T waves, prolonged PR interval. This you can answer instantly. Acute MI, what will be here? This is the 10th question. 10th, na? Yes. 10th question. 10th. Acute MI, ECG finding. Tall T waves, prolonged QT, elevation of S wave, or prolonged PR. Nice. Okay. Next. Next is a clinical question, clinical scenario. See, a 40-year-old patient complains of chest pain. ECG was taken and troponins were positive. Okay, troponins were positive. What is the next step of management? Take him for PCI. Medical management is advised. Keep right-sided leads. Keep the posterior leads. See the ECG properly. He's complaining of chest pain. Okay. Troponins were positive. Okay. ECG was taken. See the ECG properly. What's happening in this ECG? What's happening in this ECG? See properly. Troponins are positive. Chest pain is positive. And ECG is showing this feature. Now, what are you going to do? PCI, medical management, keep the right-sided leads, keep the posterior leads. Good. Good. Let's move to the next question then. Okay. Next. A patient tells her history of chest pain for 2 months before. Okay. History of chest pain 2 months before and was given medical management at that point of time. She was diagnosed as MI and she was given medical management. Now an ECG was taken. Now she is absolutely asymptomatic. Okay, it's just routine ECG she has taken. She is asymptomatic. Forgot to add this. Now she is asymptomatic. Old ECG taken 2 months before also shows ST elevations in V2, V3, V4. Okay. Now an ECG was taken incidentally. Okay. Now an ECG was taken which showed this finding. Previous old ECG showed ST elevations in V2, V3, V4. Okay. Now she is asymptomatic, completely asymptomatic. What is the diagnosis of this condition? 12th question. Old MI, patient of old MI having this feature in ECG, what will you diagnose this patient as? Acute anterior wall, old anterior wall, LV aneurysm, hyperkalemia. Old MI patient. Let's move to the next question. This is also a neat question. Which is the most common arrhythmia after reperfusion of an occluded coronary artery by fibrinolytic therapy? A. AFib, B. V.Fib, C. ventricular tachycardia, D. accelerated idioventricular rhythm. What is the most common arrhythmia? This is 13th question. What is the most common arrhythmia after reperfusion of an occluded coronary artery by fibrinolytic therapy? Come on, start answering. You are doing fibrinolysis for a patient of coronary artery. What is the most common arrhythmia you will face after reperfusion, post reperfusion? This is latest NEET question. Don't worry, even if you tell wrong answer, you can delete and make it right answer. No problem. Let's move to the next question then. Okay. So, which of the following combination of anti-anginal drugs should be avoided to avoid adverse drug reaction? Nitrates and beta blocker, nitrates and verapamil, verapamil and beta blocker, amlodipine and beta blocker. What you should avoid? What combination should be avoided for a patient? Anginal patient. Just think and answer. Whatever answer you give must have some explanation behind it. Okay? Just think and answer. Think of mechanism action of each drug and then answer. Okay. Moving to the next question. Yes. A 60-year-old patient comes to the emergency with shortness of breath. Okay. BP was 80 by 40 at that point of time and JVP was elevated. His ECG is shown below. All of the following is true for the patient except for this patient, what you might expect. pulsus paradoxicus might be seen, JVP has absent widescent, urgent echocardiography and intervention should be done for the patient, or medical management is adequate to improve the BP. What is all of the following is true except something which is false? See the ECG properly and just guess what might be the answer. All of the following is true except. If you want clue, I can say just look the height of QRS complexes. All of the following is true except I have asked. Okay. Okay. Now we will have a short discussion of these 15 questions before we move forward. Okay. Yes. First question. All of the following drugs can cause this abnormality in ECG except. What was this abnormality here? Can someone guess? You want some more time? Any question should be shown again or something? Or can we start the discussion? Yes. So what's happening here is, see this, the abnormality here is QT interval. See this is the start of, this is the start of Q and T is ending here. Yeah, QT actually if you see, normal QT interval is, you can remember by 3, 4, 5. Like if it most greater than 0.45, we call it as 0.45 seconds, we call it as prolonged QT. Okay. So if it is less than 0.34, we call it as short QT. Good. So 0.34 to 0.45 is normal QT interval. So if it is greater than 0.45, we call it as QT prolongation. What are the drugs which cause QT prolongation? So we can remember it with a short, with a small mnemonic like this one. Those drugs we use in COVID can be used to remember the drugs which cause QT prolongation. Okay, yeah, see this. So what are the drugs we will use in COVID treatment? One is hydroxychloroquine. Yes. Then we use azithromycin, macrolides. Yes. And cetirizine will be giving, which is antihistamines. And actually treating COVID patients will have psychosis. You can have like that antipsychotics. At the same time, clindamycin with fluoroquinolones. Clindamycin with fluoroquinolones, they also cause prolonged QT. And among antiarrhythmics, class 1A and 1C as well as class 3 have maximum risk for causing QT prolongation. Okay, how many small box and large box? Yes. So now see, now we have told 0.45 as the cutoff. Now we were telling greater than 0.45 seconds is prolonged QT. So one large box counts to zero point 0.2 seconds. So it should be greater than 2.5 large boxes. See here, one large box, two large box, three large box, four large box. Four large boxes are there, greater than 2.5 large boxes. So it is prolonged QT. Ranjit Kumar got it? It is prolonged QT. And the drugs which we saw used in COVID, hydroxychloroquine, yes, it's used. Azithromycin, yes, it's used. Chloroquine also, it causes prolonged QT. Digitalis will cause shortened QT interval, will decrease the QT. Got it? Can I move to the next question? Everyone understood? Yeah. Next is one basic question. Calculate the heart rate. How are you going to calculate the heart rate for this patient? See, if it is normal, if it is a regular, just whenever a question on heart rate is asked, check the rhythm is regular or not. If it is regular rhythm, we can actually easily calculate by our usual formula. But if it is irregular, then you should count 30 boxes. 30 large box you should count it. Because one large box corresponds to 0.2 second, 30 large box will correspond to 6 seconds. Okay, and heart rate is for 1 minute, which is 60 seconds. So we are going to count the number of QRS in 6 seconds and multiply by 10. So that will tell how many times the ventricle is depolarized by QRS in 1 minute. That corresponds to heart rate. Okay. So now if you count, it will be like 1, 2, 3, 4. If you count, it will come to around 17 to 18 it will come. So around 170 to 180 is the heart rate. Multiply by 10. So answer will be 150 to 200. A. Got it? If it is regular heart rate means it's easy. Like 300 by number of large box or 1500 by number of small box. Between RR interval. Like see, if it is a regular heart means you can count the number of large box between 2 RR and you can divide by 300, or count the number of small boxes between 2 RR and divide by 1500. This is heart rate calculation. Okay. Next question. Which of the following is true about stable angina? CKMB is elevated, troponin is elevated, myoglobin elevated, levels of cardiac markers unchanged. So here, can someone say what is the answer? I have asked the question as stable angina. So what will be your answer? See, we label a patient as angina or MI. It is differentiated only with the level of cardiac markers. Cardiac markers like troponin, myoglobin, and CPKMB. Okay, so in angina, cardiac markers will be negative, and in MI, cardiac markers will be positive. And if ST elevation is there, we call it as ST elevation MI. ST elevation, ST depression is there, we call it as ST non-STEMI and non-ST elevation MI. Okay, it's a simple question asked in NEET. Next, see this interesting question. 25-year-old man, come on, start guessing. Complaints of chest pain. ECG was taken. What is the diagnosis? RC blockage, LTH, LAD blockage, acute pericarditis, hyperkalemia. What is the diagnosis? See here, what is the abnormality you found in the ECG? Can someone say? Can someone guess what's the abnormality in the ECG you saw? Okay, can you some? What is the abnormality here? What abnormality you have seen in the ECG? Yes. What is getting elevated? What segment is getting elevated? Yes, someone answered it perfectly. Ashley, perfect answer. ST elevation is there. But to what kind of an ST elevation? Good, Ashley. ST elevation is, see the ST elevation again, it is concave up. See this. It's concave upward ST elevation and it is present in almost all the leads. Okay, almost all the leads you are having ST elevations. Yes, good. Satyaprasad. ST elevation is there, that too with concave upward. See, whenever ST elevation is there in MI, it will be like this, convex up. Okay, you can remember like this. Smiley is like this and smiley is like this. If it is like this, it is result in MI. If it is concave upward, it is called pericarditis. And just correlated with the history also, it's a 25-year-old boy. So you can't have coronary blockade in such 25-year-old boy. And if you see this ST elevation correlated with the ECG, you can have that concave up ST elevation, smiling ST elevation. So that will be resulted seen in acute pericarditis. Okay. Actually, in acute pericarditis, what are the ECG findings you can see is, one is this ST elevations will be there and PR segment will be depressed. See, PR will be depressed and ST will be elevated concavely. This will be depressed and this will be elevated. This is the finding with respect to acute pericarditis. Okay. Answer is C. Good. Next question. Start guessing. What is the wall of MI? Localize the wall of MI. See, whenever they ask like this kind of question, how to localize an MI, you should go and see, yeah, reciprocal ST depression. Yeah, good point, Ranjit Kumar. But see properly, it's not no. See properly, ST elevation is there in lead 1 and lead AVL. Okay, and can you find ST elevation somewhere? No. And where and all can you find ST depression? You can find in lead 2, lead 3 and lead AVF. So what is blocked? We will have the solutions to explain it easily. Yeah. So we found ST elevations in lead 1 and lead 2. We found ST depressions in these leads. What are these leads called? Lead 3, AVF and lead 2. They are facing inferiorly. So this is called inferior leads. 2, 3 AVF. And you are having ST elevation here. Yes, good. Good. These are lateral leads. So since you find ST elevation here, so you can have the mnemonic that is called EAIL. If there is lateral wall ST elevation, there will be inferior wall ST depression. Reciprocal depression will be here. This is vice versa. So as we saw here, see ST elevations in 1 and AVL with corresponding ST depressions in 2, 3 AVF, it is definitely, it's a high lateral wall MI. If it has involved V2, V3, V4, though, we would have called it as anterolateral MI. Okay, this is localization of MI. Good. Next question. This one, see, the patient complains of typical anginal chest pain. ECG was taken. What is the next step of management? See, ECG was taken, but the ECG, does ECG show any finding here? ECG is absolutely normal here. And if you take clinical features is present. Now, yes, good, Ranjit Kumar. How will you define an MI? You will define MI only with this essential criteria. Most essential criteria to define MI is presence of positivity for cardiac troponins. Essential criteria is nothing but troponin positivity. It must be there in MI. Plus anyone, like clinical features. So our patient has only clinical features and ECG is normal. So do a troponin is a must. Okay, must do is troponin to define a MI. Then apart from this, you can have clinical feature or ECG might show ST elevations or Q waves, or echo might show regional wall motion abnormality, that infarct portion will not move. Okay, that is regional wall motion abnormality. Or technetium scan, like perfusion scans can be done in that infarct area, no perfusion will be there, cold spot will be there. That is also can be used to diagnose MI. And after that, how can you diagnose MI? Just take the artery biopsy, you can find some atherosclerotic plaque. If it is there, you can also define MI. So this is a definition of MI. Troponin is must for definition of MI, along with clinical features or ECG finding, echo finding, technician scan, after that. All are supplementary criteria. So definitely, as most of them guessed it properly, that this is yes, troponins. Okay. Identify the artery affected. LAD, L6, RCA, non-localizable. What is the MA actually? What wall is affected here in this MA? Good. RCA. What wall is affected? Inferior, lateral, or anterior? Good. Ranjit Kumar, it's inferior wall. So, if you see ST elevation, it's there in the inferior wall. Inferior wall means this. You can remember like this. This is inferior wall. Leads 2, 3 AVF. And so if there is ST elevation, you should have reciprocal depression in 1 and AVL. Just now we saw. Reciprocal ST depression is there, yes. Then it's pakka inferior wall MI. Inferior wall MI, yeah, it is caused by right coronary artery. Good. Plus, if you see, there is ST depressions in V2 also. Okay. Yeah. That is plus posterior wall is also involved here. That we will discuss in the next question. Okay. Next. A 58-year-old male comes to the PHC with complaining of 4 hours with chest pain, BP normal, troponin positive, ECG showed this finding. What are you going to do? So what is this finding? What is this finding? See, if you look closely here, there is ST depression is there. Okay, ST depression is there. So it's an NSTEMI. If it is an NSTEMI, it's easy to treat, given loading dose, low molecular weight heparin, and antiplatelets. Okay, if it is STEMI, what would have done? What is the option to do for this patient if it had STEMI? What option you would have chosen? If it was STEMI, what you would have chosen? Good, Shivalakshmi. Perfect. Good, Kulnishi. Nice. Yeah, good. So, since if you see in that ECG, since it has taken more than 2 hours for shifting, you can do thrombolysis for this patient, and BP is normal for the patient, so you can start for thrombolysis. If BP is abnormal, if the patient is in shock, what does it mean? Massive wall of myocardium has already become infarcted. So even if you give thrombolysis, there won't be use. So in that case, whatever time it takes, shift him to a tertiary care center. You can't do anything by thrombolysis if he is in shock, like BP is less than 90. It is definite indication for PCI. Or if there is STEMI and BP is normal, and if it just takes less than 2 hours for shifting, then also you can go for treatment with PCI center. Shift into PCI center. Okay. Yes. golden hour for thrombolysis. Actually, ideal time, like best is if you do thrombolysis within 30 minutes is the best. You can salvage almost all the myocardium. Okay, but you can extend it to 4 to 6 hours. Okay, 4 to 6 hours you can extend for thrombolysis. You can consider for thrombolysis. PCA criteria. PCA criteria is nothing but any patient, see, any patient with ST elevation having BP less than 90, systolic BP, means is in shock. Definitely PCA should be done. Or ST elevation is there and time for going to a PCA center from a PHC, it is just less than 2 hours, means send him to PCA center. Or if it takes more than 2 hours for shifting, at that point of time only you should give thrombolysis. Got it? Cool, Nishi? Okay. Yeah. So next question. Patient has recurrent onset chest pain and on patient recurrent onset of chest pain on or for 10 months, ECG was taken. What is the next step of management? See, this question will destroy all your golden rule. Everyone told you should do cardiac biomarkers. But see this ECG properly. Actually, everyone are thinking like deep T-wave inversion, so you should go for proponents. But see this ECG properly. There are deep T-wave inversions with ST elevation. Deep T-wave inversion. See how deep is this? Okay. This deep T-wave inversions in V2, V3, V4 along with ST elevation shows that, it's not SOCM, shows that the left anterior descending artery, yes, it is completely blocked. This T wave we call it as Wellens T wave or Wellens syndrome, meaning left anterior descending artery is completely blocked. So at this point of time, you shouldn't think of doing biomarkers also. Instantly, it is the only situation where you will go and do angiography. And if you see complete block in the angiography, instantly place a stent. This is the only area where every protocol is destroyed. We will go instantly for angiography only in this area because it's a massive block is going on. These patients will be silent. Silently, they will say recurrently they will having chest pain on and off, on and off. But if you just take an ECG, you will find this deadly finding. Valence T wave should go instantly for angiography. So this is answer is coronary angiography. Got it? Yeah. Next question. Next question. So, which of the following ECG finding associated with acute myocardial infarction? Elevation of S wave, prolonged QT, tall T, prolonged PR. Good. Everyone would have guessed this. So, tall T wave is the earliest finding in case of MI. Easy question. Earliest finding is tall T waves. Yeah. Nice. Nishi, it's not tall, tented T waves. There's a difference. Blunt and broad based T waves. Tall T waves will be there. Yeah. It will be blunt. Tip will be blunt and base will be broad. Okay. If it is a tall and tented T wave, it will be resulting, it is caused due to hyperkalemia. You can remember like this K, tall tented T waves. Okay, hyperkalemia, tall tented T waves, broad blunt T waves in earliest case of MI. Good. Next, 40-year-old patient complains of chest pain. ECG was done. Troponin was positive. And what is the next step in the patient? See, chest pain is positive, troponin is positive. What will you do for this patient? It's okay, Nishi. Make mistakes and learn. See, what is the next step you are going to do? What is the finding you are seeing in this ECG? What is the abnormal finding you are seeing in this ECG? Can someone say chest pain is there, troponin positivity is there? What is the abnormality seen in the ECG? Good. Ranjit Kumar is saying as NSTEMI. Nice. Good answer. So you have told because there is ST depression in V1, V2, V3. Good. Shulakshmi, Ranjit Kumar, perfect. But see, troponin is positive and chest pain is there. You are saying it as NSTEMI. But what possibility might be there? This is the anterior wall. Yeah, good. Sachu Prasad has got it. See, one more finding what Sachu is saying. There is tall R wave in V1, V2 and V3. What does these two reflect? Just if you reciprocate this, what will come? Can someone say? Yes, perfect. Ranjit Kumar got it. See here, this is a posterior wall. Okay. Yes. So this you can say take it as posterior wall. If posterior wall is injured and infarct has gone, then you are keeping leads like V1, V2, V3, V4, V5, V6. Okay. So you are seeing here. Here you are finding R wave plus ST depressions. If you just reciprocate this, what will come? R wave with ST depression. Just reciprocally invert this, what will you have? What will you get? Q wave with ST elevation. Can you get it? That means if MI has been occurring in posterior wall, that will be reciprocally information will be given to the V1, V2, V3 anterior leads as tall R wave with ST depression. So at that point of time, as Rajat Kumar told, it can be instantly also. You should do a posterior wall leads to confirm it. If you place this leads, since MA is going on here, you will have ST elevation with Q waves in this posterior leads. So thus confirming posterior wall infarction. So you'll see this. These are the anterior leads V1, V2, V3. Okay. Whenever an MA is there, see if one wall is infarcted, just we can take it as this wall. If one wall is infarcted, the leads corresponding to that wall facing that wall will have ST elevation. And leads facing against the wall will have ST depression. This is the basic thing. So, if you have posterior wall myocardial infarction, posterior wall, then anterior wall will have reciprocal changes. If posterior wall, if you keep V7, V8, V9, it will show ST elevation means anterior wall will show reciprocal ST depressions. And QA will be forming in MI. At the same time, this Q wave will be inverted and reciprocally shown as R wave in V1, V2, V3. So, R wave with ST depression should definitely do a posterior wall leads to rule out a posterior wall MI. Got it? Illiteracy. Everyone got this? So the answer will be here, keep the posterior leads. Okay. Nice. Patient tells history of chest pain on before medical management. Now ECG was taken. ECG taken 2 months before also showed ST elevation in V2, V3. See this properly. I'm saying it's a case of old MI. Old anterior wall MI. Good. Ranjit Kumar, good. But still see, if it is an old MI, ST elevation can be there or not. And how are you saying it as an old MI? You need to answer why you are saying it as an old MI. First question. Next is, if it is an old inactive MI, no active MI is going on, then ST should be elevated or ST should be normal. Come on, start guessing. Yes, good. Ritu Bhaskaran. Q wave is present. Perfect answer. So Q wave is present means it is old MI. Perfect. So whether it's active or not. Good. Satya Prasad, pathological Q wave. Perfect. Active. Now it's active or not. Now the patient is also not having any symptoms. ST should be elevated or ST should be normal. If it is old inactive MI. Come on, start guessing. Yeah. ST should be normal. Good, Ganesh Kumar. But here, what is there? Still ST elevation is there. Still ST elevation is there. So this is the thing you should need to learn from now on. Old inactive MA means ST will be normal. If it is persistent without any symptoms means what has happened to the anterior wall, old anterior wall? It has become old anterior wall has become infarcted and this portion has ballooned out. What this condition we call it as? This infarct region this is. So, a thing we are going to learn today is ST elevation if it is persisting than 4 to 6 weeks. If it is persisting in an ECG and if no symptoms are there, then that means what has formed? Left ventricular aneurysm has formed. This is one of the complication of MI because since scar is formed in the infarction, the scar is a weak myocardial region, so that will balloon out, form in a left ventricular aneurysm. Okay, everyone got it? So ST elevation persisting greater than C for more than 2 months she is having ST elevation but no symptoms. That means left ventricular aneurysm is there. Okay. What is the most common arrhythmia after reperfusion of occluded coronary defibrillating therapy? Can someone say what this answer? See, this you should remember this the recent NEET question also. What happens is immediately after fibrinolysis therapy, the heart's conduction system starts. Okay. At that time, what happens is this is the heart, na? SA node, AV node. What happens is immediately after reperfusion, the conduction system takes time to recover. First is AV node recovers. AV node recovers and starts to form the impulse. Okay, if AV node forms an impulse, that will be at a rate of 40 to 60 per minute. Okay, so that we call it as idioventricular rhythm. Okay, but here AV node functions some faster to maintain the heart rate, like around 60 to 100. It can also maintain. AV node pushes itself to give a heart rate of 60 to 100. So at that point of time, we say it as accelerated idioventricular rhythm. Idioventricular rhythm means it should be 40-60 only, but AV node is working hard now to start back the normal contracting system of heart. So at that time, we call it as accelerated idioventricular rhythm. Actually, it is a benign arrhythmia. Nothing to be done for this arrhythmia. It is a common arrhythmia after doing fibrinolysis. AV node starts to function, only it starts to function. SA node will be taking rest at that time. Okay, AV node start pushes itself, works hard, accelerated idioventricular rhythm is formed. It is a benign arrhythmia. It is absolutely normal. After some minutes, normal SA node will start to function. Okay, this normal thing happening. Good. So, which of the following combination of anti-androgen drugs should be avoided to avoid adverse drug reactions? So, everyone was going for amlodipine beta blocker. Why? See, just see closely. If you give nitrates, what will happen? BP will fall, their vasodilators, BP will fall, and reflexively heart rate will increase. In angina patients, if heart rate increases, their workload will increase too much. So, to decrease the heart rate, we will be giving beta blocker along with it. So, nitrate and beta blocker is good. Nitrate causes sort of a hypotension and reflex tachycardia. To prevent this reflex tachycardia, beta blocker will be added. So, it's a good combo. Okay. Nitrates and verapamil, same reason. To decrease the heart rate, you can give both. But verapamil and beta blocker. Verapamil is exclusively only for the heart. It inhibits the calcium channels. And beta blocker also inhibits the heart rate, AV node, also inhibits the SA node. So if you give both, both will inhibit the AV node and it might result in complete heart block. So this combination should never be advised. Okay, got it? Yeah. So last question. A 60-year-old patient came to the emergency with shortness of breath. BP is 80/40. And JVP, what is the condition here? AP elevated. ECG, what is the ECG showing and what is the condition here? Can someone say? What is this ECG showing? I want you guys to be clear about this ECG because it's very useful. Yeah, good. Sanjay Bharati, this cardiac tamponade is showing. Why? Because just see the height of QRS complexes. It is alternating. This we call it as electrical alternance. Why is electrical alternance seen? Because if you see heart is filled with large amount of cardiac tamponade, large amount of fluid is there in the pericardium. So what happens is heart will swing in the pericardium. So first it will be in this position, and this time the depolarization vector will move like this, will produce a Q wave like this. And next time what will happen? The heart will swing there. Like it will go to new position like this. It will swing. So at this time, if depolarization starts, it will go here. So that will produce a small QRS. So large, small. This is the electrical alternance, cardiac tamponade. And see it properly, BP is reduced. That means it's compromising the heart's stability. Hemodynamic stability is impaired if BP is reduced. So heart can't completely relax and get all the blood since it's pushed from all sides with the fluid. So what we should do urgently, just take out the fluid, then only the hemodynamic stability will reverse. So urgent echocardiography is the must. And intervention, what intervention you are going to do? You are going to put an ICD here, okay, and take out all the fluids from here. That will return the back instantly, like 1 to 2 minutes. You will find the patient getting back to his normal BP. Okay, yeah, synthesis. Sorry, IC not ICD, synthesis. Then yeah, this must be the answer. JVP has absent wide descent. Yeah, this also. Next, pulsus paradoxicus is seen. Yes, pulsus paradoxicus is seen only in cardiac tamponade. Then, medical management is adequate to improve BP. Never. Medical management can't do anything here. Because since the tamponade is causing hemodynamic instability, medical management is not a treatment of choice. You go instantly do the echocardiography, find the fluid, insert a needle, remove the fluid, the patient will Instantly recover. This is an emergency and instantly make the patient recover from the pathology. And you should then go on search for the cause of this cardiac tamponade. Okay, good. Yeah, we'll proceed. One easy question for you. Heart rate between 250 and 350 is seen in atrial fibrillation, atrial flutter, SVT, sinus tachycardia. Come on, answer quickly. So at this point of time, you should know this also, like painless pericarditis. Which pericarditis won't cause pain? Okay, you can remember as uremia, uremic pericarditis, or if it is some malignancy, or if it is TB, or if it is radiation. All these pericarditis won't cause pain. Usually pericarditis means chest pain will be there severely. Okay, but these pericarditis won't cause pain. Uremia, malignancy, TB as well as radiation. Good. So heart rate between 250 and 350 is nothing but yes, it is atrial flutter. So 100 to 250, 250 to 350, 350 to 450. This is atrial fibrillation. This is atrial flutter, and this is SVT will have. Okay, good. Next. Okay, next. So, what is this condition which is commonly seen with which of the following drug toxicity? Start answering. Commonly seen in which of the following drug toxicity? Usually, they will ask these two questions. I have this question is more important with respect to need. What is the ECG, this abnormality seen with some drug toxicity? Good, Satya Prasad. Perfect answer. Okay. Nice. Can we move to the next question? Okay. See this ECG. All of the following are true for the condition except see ECG properly. No answer. Pulse will be regularly irregular, absent A wave in JVP. Hyperthyroidism can cause this condition. It is identified by disappearance of presystolic accentuation in diastolic murmur of mitral stenosis. So, all of the following is true for this condition. What is this condition? It's given in the ECG. See the ECG properly. And now guess what is the all are true except some statements fall in the false in the following statements. Pulse will be regularly irregular, absent A wave in GVT. Hyperthyroidism can cause this condition. It is identified by disappearance of peaceful accentuation. Start guessing. Good. Next. So, drug of choice for this ECG. This ECG, if you see, what you will suspect and what is the drug of choice for this ECG. 19th question. If this ECG is given, what drug of choice you can give for this ECG? Just see what's happening with this ECG. I given a clue also. So drug of choice for this ECG is amiodarone, lignocaine, phenytoin, digitamide. Okay, next. A 60-year-old patient developed MI 1 month, 1 year before. Okay, now has complaints of palpitations. BP 80/40 mercury. ECG is shown. What is the next step? Patient is having this ECG. So diagnose what is going on with the ECG. Okay. Then the patient is having BP of 80/40 and he has developed MI 1 year before. So this 60-year-old patient. Now what are you going to do? Next step. Are you going to give IV lignocaine, IV amiodarone, DC cardioversion or CPR? Excellent. Excellent. Okay. Next. What is the diagnosis of the ECG? Mobitz type 1, Mobitz type 2, complete heart block, sinus bradycardia. What is the diagnosis of this ECG? You can see in Zoom also. What is the diagnosis? Mobitz type 1, Mobitz type 2, sinus bradycardia, complete heart block. Can I move to the next question? Okay, next. You are a resident posted in a PHC. A patient comes to the PHC with complaints of giddiness, lightheadedness, fatigue for past 1.5 hours. Okay, what is the appropriate next line of management? See this ECG. Patient is having symptoms of giddiness, lightheadedness, fatigue for 1.5 hours. What is the most appropriate next line of management? See this ECG properly and then decide whether are you going to give a atropine or refer to tertiary hospital for pacemaker implantation or observation for some time, and if it's still asymptomatic discharge, send patient home as there are no MI changes. What are you going to do for this patient? I'm focusing the ECG more. What are you going to do for this patient? See this strip alone. See this strip alone. You will get it. We have discussed the approach also to bradyarrhythmia. Just apply the approach here. You will get it. Are you going to give atropine for the patient or refer to tertiary hospital, observation and discharge, or whether are you going to send the patient now itself? Excellent. Excellent. Next question. The neat question. Which of the following statement is about Dressler's syndrome is false? It occurs as pericarditis as well as pleuritis. It is an autoimmune phenomenon. First, the line therapy consists of aspirin. It occurs 2 to 7 days after MA. What is the statement about Dressler's syndrome is false? Pericarditis pleuritis, autoimmune phenomenon. Excellent. Start guessing. Come on, start guessing. Okay. Next. What is the diagnosis of this ECG? What is the diagnosis of this ECG? It is 24th question. What is the diagnosis of this ECG? See this question. See this ECG properly. Okay. I am going to zoom this ECG also. See this properly. See the strips. See this strip and apply our algorithm. Good. Okay. Next. Last question. What does the marked wave represent? What is this the marked wave? Okay. What does this wave represents? This wave. Depolarization from endocardium to epicardium. Depolarization from epi to endocardium. Repolarization from endo to epicardium. Or repolarization from epi to endocardium. Last question. Simple one. What does this wave of an ECG represent? Depolarization from endo to epi. Depolarization from epi to endo. Repolarization from endo to epi. Repolarization from epi to endo. Yeah, it's a simple one. Good. Perfect. Good. Excellent. Yeah, perfect. Perfect. Let's start discussing. Yeah, actually, things I wanted to discuss is, yeah, this one. What is the abnormality shown here? See here, this is something interesting only with digoxin. What digoxin does to the heart is it is vagotonic. Vagotonic means it stimulates the vagus nerve, and vagus nerve, what it will do to the AV node? It will block. It will block these SA and AV node. At the same time, it stimulates the atrium and ventricles. This is what digoxin does. Stimulates the ventricle by calcium loading. So what will happen if you give digoxin? Heart rate can be reduced, yes. impulse conduction can be blocked. AV block can happen. Yes. Then, if atrium is stimulated continuously, that can result in atrial flutter or atrial fibrillation. Okay, the characteristic finding which digoxin causes is by stimulating the atrium by calcium loading, it causes atrial flutter. At the same time, it blocks the AV node. So, how can you find atrial flutter in ECG? See sawtoothed waves like this. See this sawtoothed waves. So, see this three P waves are produced and one QRS is coming. That means three is produced and one is conducted. So this is actually 3:1 block atrial flutter. But actually, as Sachu Prasad told, atrial flutter with 2:1 AV block is the most common finding with respect to most common this thing finding you can expect in digoxin toxicity. So most common is seen with digoxin toxicity. Okay, atrial flutter with 2:1 AV block. Next, what is this condition? What is the ECG showing? Good. Ashley, perfect. See this ECG. If you see the RR interval, what's happening here? It's increased, decreased, decreased here, again increased, meaning irregular. If heart rate is irregular, you will go and see for the P waves present or not. Are the P waves present? No, no P waves is there. If P wave is absent, you will be saying as atrial fibrillation. So in atrial fibrillation, pulse will be, how will be the pulse? Irregularly irregular. This is the false statement. Absent A wave, yeah. This A wave absent because atrium is not contracting. Then hypothyroidism can cause this condition. Yes, absolutely. It is identified by disappearance of systolic accentuation in diastolic murmur of MS. Again, it's yes. True statement. See, in MS, what will happen is in diastole, between S2 and S1 is diastole. No? In diastole, usually there will be a mid-diastolic murmur in MS with, when it approaches the systole, there will be pre-systolic accentuation caused due to atrial contraction. Okay. So, in fibrillating atrium is just dancing, it's not contracting. So that means this accentuation won't be there. That means atrial fibrillation has started. Okay. That's it. So answer will be this is the false statement. Yeah. Good. What does this ECG show? That's what I told. Presystolically, atrium is not contracting. It's just dancing, fibrillating. So there is no presystolic accentuation. Good. What is this ECG show? See this QRS complexes. It is going in both directions. Yes, it's tachycardia. Less than 3 large boxes, it's tachycardia. And it's bidirectional tachycardia. Sachu Prasad, bidirectional tachycardia. That means what drug can cause bidirectional tachycardia, as we are discussing digoxin, by stimulating the ventricles continuously, what will happen is some ectopics will originate in the ventricles. Like this ectopic will fire now. Okay. The depolarization will go from this direction, leading to one Q wave. Then this ectopic will fire in this direction. So it's going opposite side now. So this Q wave will be this like this. Next, this will fire. So if you see, it will be a bidirectional tachycardia due to these ventricular premature complexes contributing to the bidirectional tachycardia in digoxin toxicity. So since I have told it's digoxin toxicity, what is the drug of choice? It was digibind. Drug of which, if it is digibind is given, then you should go definitely for digibind. because it's perfectly against digoxin. Whereas lignocaine is yes, any ventricular tachycardia due to digoxin you should give drug of choice lignocaine only. But still, since digibind itself is given in the options, you should go for digibind only. Okay, good. Next, what is this condition? 60-year-old patient developed MI. See, he is a post MI patient. How will you approach this ventricular tachycardia? How will you approach ventricular tachycardia? See here. If it is ventricular tachycardia, first step in approach and treatment of ventricular tachycardia is go see for the patient's hemodynamic stability. If BP is less than 90, patient is unstable, then no any medical management. Just go immediately for DC cardio version and instantly do CPR. CPR for 3 times. Then again try for DC cardioversion. You can repeat this for 3 times. This is for unstable patient, instant DC cardioversion with CPR. Okay. If the patient is stable, good. See whether the patient had old history of MI or not. If post MI is there, then you should give lignocaine. Otherwise, what you should give? Will give? Otherwise, amiodarone is drug of choice for all ventricular tachycardias. Lignocaine is not working, go for amiodarone. Okay, so ventricular tachycardia, see for hemodynamic stability, unstable DC cardioversion, stable, go for amiodarone as well as if it's post MI, go for lignocaine. This is the management protocol of ventricular tachycardia. Next, what is this diagnosis? So yes, now you should know how to approach a bradyarrhythmia. So let's discuss what we have seen earlier. How will you approach a bradyarrhythmia? Say, first you should see for the heart rate. Okay, heart rate you should check. If heart rate is less than 60, okay, then it's bradycardia. Then check whether P wave is there or not. If P wave is there, then proceed forward. If P wave is not there, P wave is produced by SA node only. So problem is there in the SA node or even in atrial fibrillation if you give too much of rate control agents like beta blocker, too much of beta blocker and all if you give, then also it will go into slow ventricular rate. That will also cause bradycardia. So if P wave is not there, then you can think of SA node problem or atrial fibrillation with excess rate control agents. If P wave is there, then check the PR interval. Whether PR interval is varying or constant. Meaning, check for the PR interval in one lead, in one area, then go and check for the interval, other subsequent PR intervals. If it is varying, then only two diagnoses. One is Mobitz type 1 and next is complete heart block. Okay, if it is varying, it's very easy for you to diagnose. So how will you differentiate these two, complete heart block and Mobitz type 1? Go. See for the, if it is varying PR interval, look for the RR interval and PQRS relationship. If RR interval is constant, like it's not varying, and if there is no PQRS relationship, like P should be followed by QRS. If it is not, if it is like confused state, P somewhere P will be there, somewhere QRS will be there. It is like that. Then we call it as AV dissociation will be seen in complete heart block. If PQRS, P is followed by QRS, and if RR interval is irregular, then it is Mobitz type 1. Okay. Next, what will happen if PR interval is constant? All the other bradyarrhythmias like Mobitz type 2 and first degree heart block, sinus bradycardia, and what is one more thing left? advanced second degree heart blocks. Then what you will go, if it is constant PR interval, look for the PQRS relationship. If there are only one P followed by one QRS, okay, then you can measure the PR interval. PR interval is normal. See, in a ECG, PR interval is normal, okay, and RR interval is normal, and what now we saw, PQRS immediately after P wave QRS is coming. Everything is normal means then it is sinus bradycardia. Or everything is normal, only PR interval is prolonged, meaning greater than zero point 0.2 seconds. Then we tell it as first degree heart block. Okay. Then if you should see whether if it is P is greater than number of QR, number of P complex is greater than number of QRS means check for the amount of dissociation. Like if it is 2P followed by 1 QRS or whether it's 3P followed by 1 QRS. If it is like this, then we call it as 2:1 heart block, 3:1 heart block, like that. Okay. If it is 3:2 means like this, 3 P waves. Then we will go for Mobitz. Okay. This is the approach with respect to bradyarrhythmia. So, like this, if you approach this ECG, what will happen? See, first we are seeing the heart rate. Heart rate is definitely more than five large boxes. Bradycardia is there. Then what are you going to see? P wave is there or not? P wave is, yes, it's here. Okay. Then what are you going to see? PR interval, whether it's constant or varying. See the PR interval here, like one large box it's coming. Okay. Same thing. It's not at all changing. So it's constant. Then what are you going to see? Whether every P wave is followed by a QRS or not. Yes, it's following. Okay. Then we are going to measure the PR interval. See the PR interval? It's like 0.2 seconds. PR interval is also normal. Everything is normal in the ECG except for decreased heart rate. So we can go for sinus bradycardia. Okay. Next, what is this condition? Again, same approach I am going to approach. Okay. What is the thing? First, it is bradycardia is going on. Okay. Next, what are you going to do? See the PR interval, whether it's constant or varying. See the PR interval here. It's two large boxes. It's coming to 1.5 large boxes. It's coming to one large box. It's coming to less than one large box. Okay. It's not constant. It's varying. Varying can be complete heart block or Mobitz side point. Okay. So now you are going to see the RR interval. Whether RR interval, how it is there. See the RR interval. How it is there? Sorry, PR interval. Sorry, big mistake. PR interval actually is constant here. Sorry, PR interval is constant, and each P is followed by QRS. But check for the amount of PR interval. Two large boxes coming, so it's more than 2.2 seconds. Only PR interval is prolonged, otherwise normal ECG. Then that means it is what degree heart block? First degree heart block. And if the patient has symptoms means you should immediately give atropine for this patient. Good. Ashley, first degree heart block. Next, restless syndrome. What is false regarding restless syndrome? Actually, restless syndrome, if you see, more than 1 week after MI, what will happen is post MI, after injury, those antigens will be released into the blood. Okay, it's a hypersensitivity reaction. So what will happen is antibodies and our RBC starts attacking the surrounding area of the heart, which is the pericardium as well as the pleural tissue. So there will be pleuritis, pericarditis, yes, autoimmune phenomenon, yes. First line therapy, it's since an autoimmune phenomenon, will be giving NSAIDs, anti-inflammatory, to control it, and it doesn't present within 2 to 7 days. It presents after 1 week. The answer is D. Next, what is this ECG? Yeah, this you can see. Here it's bradycardia is there. Yes. Next, what are you going to see? P is there or not? Yes. And then next we are going to see PR interval, whether it's varying or constant. See this PR interval? It's getting prolonged until followed by a missed beat. Short PR interval here. Getting prolonged followed by a missed beat. This is Mobitz type 1, or you can have it as Wenckebach's phenomenon. Good, Satya Prasad actually. What does the marked P wave represent? Just represents P wave, which is depolarization of the atrium. Depolarization also always starts from endocardium to the epicardium. Okay, yeah. Now you can announce the results. The winner. First three portions you can announce. You can say you can see the first six members who are the first six members who have got prizes. First goes to Sattu Prasad. Next, Suvalakshmi. Next, Ilavarasi. Third. Fourth goes to Sanjay Bharti. Fifth goes to Nishi. And sixth goes to Kartika Shiva. Congratulations, everyone. So we'll be having video lectures continuing on clinical cardiology hereafter. Okay, this week we'll finish cardiology and JVP, arterial pulses. We will be seeing different type of pulse as well as heart sounds and murmurs. Good. Congratulations, Satya Prasad, Lakshmi, Ilavarasi, Sanjay Bharti, Nishi, as well as Kartika Shiva. Yeah, we'll be having further sessions. Okay, thank you.